Hello, everyone. Welcome to another Saturday with a session with an internal medicine residency. Today, we have the pleasure to receive the University of Washington State, and we are super happy. They have been here before, and we are excited for the case and know a little bit more about the program. And I'll ask them to introduce themselves. Dr. Yang, you could start.
Hi, good morning, everyone. I'm Yihan Yang. I'm one of their core faculty members for the residency program. I've been with this program for about 2 years. I'm really excited that we finally have our full 3 classes because we're a relatively new program. I think outside of medicine, I enjoy spending time with my 2-year-old daughter and watching her learn to walk and talk and all sorts of troublemaking. But most of the session today, I hope will just be sort of highlighting Dr. Kevin Chang, Dr. Tosin Fajana, and Dr. Aisha Alam's experience in our residency program. I'm mostly just here for moral support.
Thank you so much. Kevin, you want to go next?
Yeah, thanks again for having us. I'm Kevin Chang. I am originally from Canada. I did my medical school in Australia, and a few months ago, I relocated back here closer to home in Washington State. I'm currently a first-year internal medicine resident, and outside of work, I've been taking full advantage of this new environment. I've picked up pickleball, I've been hiking more, and I'm very excited to start this new chapter of my life.
Amazing. And then we have Dr. Fashana.
Hi, everybody. It's really nice to be here. My name is Tosin Fajano. You could also call me just Tosin as well. I'm also an IMG. I grew up in Nigeria, also went to medical school in Nigeria as well, and relocated to the US a few years ago. I'm also a PGY1 resident as well. Outside of medicine, I love to travel. I love to take road trips. But right now, I currently have an almost 6-month-old boy who's keeping me very busy. So I love to spend time with him.
Amazing. And we have the last one, Dr. Aisha Alam.
Yeah, hi. Nice to meet everybody. I'm Aisha Alam. I'm one of the second-year residents at Wazoo IM program. I'm also from Canada, from Vancouver, BC, so just a couple hours north of where our program is located in Washington. And I studied in the Caribbean. I really enjoy spending my time golfing after work, so I do that quite a few times a week.
Amazing. I love it. I think we can start with the session. Sarah can share the whiteboard, please.
Awesome. I can start with the chief complaint. And I'll take some pauses in between and for everyone to ask more follow-up questions. So essentially for our case, we have a gentleman in his early 30s. He presented to the ED with a right-sided chest mass. That is his chief complaint. He recalls that a few months ago when he was doing push-ups, he started to hear a pop on the right side of his body. He went to see his PCP, who prescribed him some Flaxerol and Toradol that had very minimal relief for the pain. The PCP also ordered some imaging, but unfortunately, the patient was lost to follow-up. The patient presents a few months later now to this ED because he feels like the pain has increased in size. The lump has increased in size, and it's giving him some arm pain, and he has difficulty now fully raising his arm because of the pain. Is there anything else you would like to know?
Oh, this is an awesome story. Thank you so much, Kevin. I'll hand the mic to Yaz or Bettina if they want to get us started.
Of course. I think that when I listen to chest mass, I'm thinking this is just like to be sure, like this is on the skin, like a chest mass on the skin, or like inside
He just describes it as a chest mask. We can go into
Okay.
physical exam later.
Okay, perfect. Well, when I listen to chest mass, I will the first thing comes to mind is maybe an abscess. If this fluctuates, if this is painful, if this has rubor, tumor, or pain, and also like seeing that it has been increasing in size and now it's producing arm pain, I'm wondering where is localized, like what part, like anatomically speaking, if it's only skin, like subdermal tissue, if it's in muscle, where is this coming from? If this was a chest mass found like an X-ray, we will have like mediastinal mass against versus lung mass. And then I'm thinking flexural and toradol, if they are not providing any relief, I may think this chest mass could be extending to any nervous structure. So that's where I'm trying to situate this now that I'm listening, that is producing arm pain and difficulty raising the arm. I would definitely love to hear Bettina's thoughts.
Yeah, thank you so much for getting us started. Yes, I think most of my thoughts were already explained so well by you. So for me, when I think about this chest mass, the two buckets that I think about would be neoplastic versus infectious. So yeah, I would probably ask the same things, any history of malignancy, family history of malignancy, the characteristics of the mass itself, like what Yas said, any signs of inflammation, of course, since we're talking about infectious, probably a more detailed history about travel history, exposure to pets. And I love what Yas said about it probably affecting the nerves or the muscles because the patient is already having a difficulty fully raising the arm. So yeah, that's all I have to add for now. So
y'all are just absolutely amazing. I have very little to add. I love the anatomical approach, yes, to the chest mass, thinking like which compartment is involved. Bettina thinking about neoplasm, absolutely spot on. That's definitely a no misdiagnosis. And the other thing that I'm wondering is just the context that this mass is in, right? Like, who is this person? Is there any other systemic signs? Like, is this an isolated mass in the chest, or is it part of a more systematic process? I'd be curious to know if there's any like B symptoms, like any fevers, chills, any weight loss that this person has experienced. And 30-year-old, is this someone who's had any, as you mentioned, Bettina, like exposure history, like any things that I would ask about social history would be like health related behavior, like drug use, especially like injection drug use. To think about like kind of HIV risk factors, to think about sexually transmitted infections, to just kind of get a better picture of this person. And again, to know if there's someone who's been in care, are they any past medical history that would change the context for us as, this is a healthy 30-year-old presenting with a chest wall mass that is expanding, like kind of a subacute nature of it, or is it someone in the context of someone who has underlying immunodeficiency, underlying diseases that would kind of change our calculus. So I'm excited to learn more from you all.
Yeah, I think both of you made really good points. And that's definitely the approach that we took as well. So just going through a few other characteristics of this pain, I kind of went down the Socrates route for the site. It's a right-sided chest mass that's actually more in between the breast and the armpit area in the axilla. Onset was a few months ago. The character, it's a dull, constant pain. There's no radiation. And in terms of his associated symptoms, some of them include he has a weight loss of over 30 pounds in the past few months. He also has been having some nausea, vomiting, and loss of appetite. He thinks it's due to nutritional deficiency, so he's been taking a lot of Tums lately. Other than that, he doesn't have any numbness in his arms, and he doesn't have any other motor weakness otherwise. He mentions that he's been having difficulty opening both of his eyes, but the left side is worse than the right. And this mass is large. It's a tennis ball size. And it's not really painful to palpation, mainly pressure. In terms of his past medical history, he is previously healthy. He doesn't have any past medical history. No recent trauma or injuries to his chest or any parts of his body. For his medications, he doesn't currently take any medications at home other than the Tums that he takes because he thinks he's nutritionally deficient. His past medical history includes hemochromatosis for his mother, which is making him very concerned. He feels like this might be related, and also MI for his dad. So he has quite the social history. He works in tech, but he's been traveling a lot lately because of work. He's traveled to over 10 countries, including those in the Middle East, in Southeast Asia, and in Africa. He has over 30 sexual partners with protected and unprotected sex. And he currently lives at home with his roommate, who has 2 cats. In terms of his health-related behavior, he generally lives a relatively healthy lifestyle, and he hasn't seen a regular PCP for a while, other than that one time for the chest pain. He doesn't have any known drug or food allergies.
Kevin, I feel like this is every infectious disease doctor's like perfect history taking. So this is fantastic. Thank you so much. So much for us to discuss. Bettina, do you want to take a stab?
Yeah, sure, absolutely. So, clinically for me, the patient seems to be presenting with a lot of systemic symptoms. So right now, I'm probably leaning more towards a neoplastic cause. But then we went to the social history, and then there are so many risk factors that made me wonder, is it probably infectious? It could still be infectious. So I don't want to completely close my door on that. And so I was thinking, between the axilla and the breast, one thing that jumped out at me is it could be a lymphoma. So that's one of the neoplastic differentials that I'm thinking about. And with the difficulty of opening of the eyes, I'm thinking, it could be the cranial nerves, yes, but it could also be ptosis, which is probably due to the impingement of the sympathetic ganglia that could be in the chest wall. So that could be in the chest area. So it's still in line with the patient's presentation. And so so right now for me it's more neoplastic than infectious, but I also want to consider those risk factors right now. And I think looking at the physical exam can help us further when we characterize more the lesion. So how about you, Yaz?
Yeah, I'm definitely with you there. When I listen to all this social history, something I would like to investigate about is that this person has something called the apraxia of the eyelid, which is like they cannot elevate the eyelids and they cannot open it. So many times we think maybe this could be structural, this could be genetic, could this be neuroinflammatory or neurodegenerative? Like this is a very young person. So we already say like this person has bad genes, bad luck, or a risky behavior. Now, genetically, a cause of apraxia could be any issue on dystonic proteins. Now, for the onset, I will go more into neuroinflammatory or maybe infectious issues such as Bell palsy, because this person has more just for the onset, as well as myasthenia gravis that present with oculomotor fatigue. I could also put in, as you mentioned, neoplasms. And neurodegeneratively, this is a very, very young patient. So that will be like last in my differential diagnosis. I'm thinking also like, if I'm not wrong, TUMS can cause electrolyte issues, but then again, we will see that on his labs. And so far, that's everything. Oh, and the past medical history, like family history of hemochromatosis in her mother, could predispose this person to have maybe infiltrative disease predisposition. So that's also another thing that I am wondering. What do you think, Dr. Charmaine?
I think you guys are brilliant. In addition to that, I totally agree. I think this just expands our differentials rather than limit it to, as Bettina mentioned, like a systemic disease, right? The weight loss, I'm really worried about this person, right? Like 30-pound weight loss, that is a lot, especially for a young, otherwise healthy person. So this is someone who coming in with, like, as you mentioned, like kind of like B symptoms, weight loss, with an expanding chest mass for months, in addition to the eye finding. Yes, I loved your discussion about the eye finding. So thinking about whether this is neuro, or is this kind of like muscle involved, or, thinking about like the location of mass, or like something like SVC syndrome that we have to consider. Again, it's very broad, but the two buckets that I also am leaning on is this a malignancy, or this kind of an indolent infection. So thinking about his behaviors, like this is someone that we definitely want to do STI testing. We want to get an HIV test. And because of all the travel history, as you all mentioned, that also puts him at risk. Whether the question is like, is this someone who has like some chronic immune deficiency that now has something on top of it, or everything that we're seeing can be explained by one disease process? So that is like the two kind of reasoning paths my brain is taking me on. And in terms of like infections, like TB, we had a case in VMR, a chest wall mass that came out to be cutaneous TB. And so it's hard to not anchor when you have a case, like you've seen a case like that. But again, thinking about it, multi-system involvement of diseases that can cause weight loss. So your indolent infections and like mostly like hematologic malignancies are the two things that are on top of my list. I love that with the thumbs is that the other question I was asking is like, what is the calcium level with that amount of thumb, and whether that is playing a role here as well. Again, like kind of getting the exam that helps us establish like the acuity, how urgent we need to do our workup, and then getting some labs to be able to better differentiate what is in the background and what is the foreground of this case. All right, we're on the edge of our seats.
All right, I love to hear the reasoning. Before I go into the physical exam, I might just add a few negatives, relevant negatives. So he does not have any, he mentions that he doesn't have any rashes, he doesn't have any fevers, he doesn't have a family history of autoimmune disease or breast cancer, he doesn't have any joint stiffness or pain in the morning or otherwise. So moving on to his physical exam, he's afebrile, he's normal cardiac, normal tensive, and breathing well on room air. In terms of his general exam, he has a BMI of 19, and he has some temporal wasting, but he's otherwise non-toxic looking. For his eye exam, we see some bilateral ptosis that is worse on the left side than the right. When you try to open his eyes and have him track your fingers, he has some diplopia. And the ptosis doesn't get worse with use, so it's not fatigable. His cardiovascular exam was unremarkable. Heart cells were dual without murmur, and his chest was clear with good air entry and no abnormal breath sounds. Abdomen soft and non-tender, couldn't really palpate any hepatomegaly or splenomegaly. And his neurological exam, he was alert and oriented and has no upper or lower extremity motor or sensory deficits. And for the extremities and the skin, I might just share my screen to show you a picture of it, if that's okay. I think this picture will say 1,000 words.
I just made you co-host. I think you can share now.
Yep. All right, so this is what the mass look like. Can you see it?
Yeah.
All right, so what are some thoughts?
Wow. All right, Yaz. What do you think?
Well, the first thing that came to mind when listening that this patient has temporomandibular wasting is that this person has been under chronic inflammation, and therefore there is something. Now I'm thinking more on a neoplasm or a very aggressive infiltrative disease. Now, definitely my next step would be trying to localize, like, what is this mass made of? It doesn't look, it looks red, and but it doesn't give me the idea of being an abscess. Now, with this very interesting findings of ptosis being in both eyes, myasthenia gravis, I think, got like a step upwards, like on my diagnosis, differential diagnosis, aside from the neoplasms. I am really thinking about something going on skin, as I think I already saw it on the chat over there, like any sarcoma. Again, TB can present with cutaneous masses, but then again, I'm really, like, I'm impressed by this mass, honestly. What do you think, Bettina?
Yeah, amazing discussion. Yes, I was also wondering about the bilateral ptosis. So, just for transparency, I'm actually writing notes, and my first line in this aliquot was bilateral question marks. I was wondering about that because earlier I was saying that it could have been impinging on the sympathetic chain, but now that it's bilateral, it's making me wonder, why is the other side also affected? So that's one question that I still have until now. And honestly, I'm not quite sure how to explain it yet because it's non-fatigable. I was also thinking about myasthenia gravis, but with that finding, I'm kind of not sure about that one. With the picture, it was really interesting that I saw erythema on that. So now I'm thinking about, it could still be infectious, even if the background is neoplastic. And it's made me wonder, we've had VMRs also in the past that we were thinking about neoplastic versus infectious. And, what happened in the end was that it was both. So, maybe there is a neoplastic process that is happening in the background that's led to the patient becoming more immunocompromised and then leading to an infectious mass that could happen in the patient. So that's something to watch out for as well. So aside from TB, I'm also thinking about nocardia, actinomyces, and yeah. So I'm still thinking about both things, and probably happening at the same time or just maybe one or the other. So yeah.
Yeah, I totally agree with you. Both. Again, like kind of starting from the top in terms of the vitals, like patients like afebrile, with vital signs that is within normal. So, okay, we have some time to dig into the other exam. And yeah, in terms of like the ptosis that is bilateral, I totally agree with how you all are framing it. So I was like also thinking about like, okay, what is it, right? Is it the upper motor neurons? Is it the nerves? Is it the neuromuscular junction? Or is it the muscles itself? And with the neuromuscular junctions, yeah, myasthenia gravis is a good thought. The fact that it's not fatigable makes it a little less likely. The other one to think about it, would be like Lambert-Eaton. Lambert-Eaton is also like associated with like underlying malignancies like lymphoproliferative disorders as well. So So that is something to think about if we're trying to connect the systemic things that is going on with the ptosis. The other thing you don't want to miss out is, like, again, like orbital mass or anything that is putting pressure. So definitely some form of imaging to better characterize and make sure like that is part of a systemic and not something that is in the head and the CNS itself. That could explain the diplopia and the ptosis together. In terms of the rest of the exam, you know, again, like the weight loss, and now we have like the objective evidence of the fact that this patient is catectic, and it makes me, as you all mentioned, very concerned for an underlying either malignancy with paraneoplastic syndrome or an infectious etiology. And in terms of the mass itself, I was curious, was there any bruit, Kevin, when you were listening to it, or somebody was listening to it?
There was not.
So thinking about, like, you know, the redness of the erythema of it, the reason why I asked was like, oh, if this is like more of an angiosarcoma or like something that has a lot of vessels in it. So it looks quite concerning and quite big. So thinking about whether this is could be a skin and soft tissue or muscle involvement to it as well, and has a lot of blood vessels that makes it like more erythematous looking. And so the things that I want to like get a better lay of the land. So getting our labs, like especially if you're thinking about like, oh, we're concerned about our lymphoma, looking at the CBC would be really helpful. This is someone that definitely warrants some imaging, and as mentioned before, like doing your HIV testing. I think, and then thinking about more of your indolent infection is where I would go. I would not yet go after a biopsy of a mass. I would want to characterize it a little bit better before thinking about like a biopsy.
All right, sounds good. Should we go into some labs and some imaging? All right, I'll let Tosin present this part.
Yeah, so we did some initial workup for him. The white cell count was 4.83, hemoglobin was 14.5, platelet count was 195,000, which is essentially normal on presentation. The CMP, the sodium was 143, potassium 4.9, BUN 23, creatinine was 1.24. The albumin was 4.6, total bilirubin was 0.7, total protein was 8.3. ALP was also 60 as well. Alk phos was 60. Magnesium 2.2, and the calcium was elevated at 13.6. Troponins were normal, and the GFR was greater than 60. Any initial thoughts on the chemistry and hematology?
Bettina, what do you think?
Yeah, so I was wondering, with the CBC, were there any blasts seen or no?
I believe the prior CBC, the prior hematology was also normal as well.
Okay, great. So yeah, for me, what I saw, what stood out to me was the calcium. I'm not sure if it would be because of the medication that the patient took, or it's a sign of something more underlying in the patient. One thing that I thought about immediately when I saw the calcium is, could there be a granulomatous disorder? So that's something that I have to dissect further, and hopefully with more of the tests, we can further get a clearer image of that, especially when we also get more imaging for our patient. With the calcium, I also want to get is it from the PTH, or maybe, sometimes malignancy can also have a paraneoplastic disease that can cause the hypercalcemia. So the PTHRP. Yeah, so the ferritin and the LDH, to be honest, I'm not so familiar with how to dissect that further, so I will leave that to the two of you. So yeah, that's it for me.
Yeah, Bettina, I completely set on the calcium too. As far as I will say, well, my next step would be asking for a PTH, and according to that, determining if there is urine calcium or calcitriol to determine if this could be, as you mentioned, a chronomatous disease, such as sarcoidosis, lymphoma, if there is any other causes, if this could be just because he takes a lot of Tums, could be, or if we have hypercalcemia of malignancy. Now, looking at this LDH, I am wondering, I'm putting this, prioritizing this diagnosis, hypercalcemia of malignancy, after seeing these levels. Now, because of the onset, taking a step back, I'm thinking this person has had this for a few months. So or this is a neoplasm that is not very aggressive and progressively growing, or this could be an indolent infection. Again, not to anchor on TB and infectious disease, but a cold abscess, and makes me think of a cutaneous tuberculosis. So those are my two priorities now. See if we should get a workup with PTH, and see if we could have a TB workup as well. Again, that will be my main ideas. What do you think, Dr. Charmaine?
No, beautiful discussion. I totally agree. And how did you all know I love hypercalcemia? I am definitely a calcium girl, not a sodium girl. So yeah, I agree with you guys. So thinking about figuring out whether this is a PTH or non-PTH mediated. And I think our biggest suspicion is for non-PTH mediated. Going back to a lot of Tums, that definitely clouds up the picture, like how much of it is because of his increased ingestion and how much of it might be in a setting of his underlying disease. The one thing that I would point out about his creatinine of 1.2, this is someone who's like BMI of 19, who's completely catectic. So most likely this patient already has an AKI, but they don't have the creatinine to allow for seeing that in the usual elevated creatinine that we see. So I'm worried as someone who's really catectic, I don't trust the creatinine as much. So that's something to note of. In terms of as you all mentioned, PTHRP, a lot of squamous cell cancers and renal cell carcinomas are associated with that. Thinking about your vitamin D, I would get a vitamin D level, both the hydroxy and dihydroxy, thinking about whether this is a granulomatous process, as you mentioned, Yasmin, with your concern for TB. And then the other thing to think about, aspects that cause lytic bone lesions, and the mass being so close to the breast, breast cancer can definitely cause some bony lesions that lead to elevated calcium. And myeloma, again, in this age group, probably less likely. And then the lung malignancies. Again, breast cancer, thinking about sometimes in men, BRCA-associated breast cancers can present in this age group. And then we talked about kind of the milk alkali syndrome as well. So the other thing to think about with the LDH, I love thinking about, the lymphoma as a possibility. Oftentimes with LDH, thinking about malignancies like lymphomas, leukemias come into mind, but aggressive solid cancers, anything that is aggressive that causes a lot of cell bursting can cause your LDH to be elevated. I think for the next steps, the other thing that I see when I see an elevated LDH, I just want to make sure this patient is not hemolyzing, the hemoglobin is stable, trend that to make sure, however, probably lower concern for that. And in terms of leukemias and lymphomas. With the leukemia, with the white count of 4.8, no blast, probably makes it acute leukemia in my mind a little less likely. Lymphomas are still definitely in the picture, but interesting to me, oftentimes when people are like presenting very catectic, usually they have some anemia, like the platelets is like starting to downtrend, but we're not really seeing that many things that light up, right? So we don't see that many reds at the board. But again, like this is a young patient. So I still would love to see an HIV. I agree with Yaz in terms of a TB testing, getting your calcium workup done, and then see what direction this case takes us to.
Absolutely. Thank you so much for the very thorough and extensive workup on hypercalcemia. We also went ahead to do some other labs and very interesting comments in between. So I'm just going to go through some of the other laboratory workup that we did. We went ahead to do hepatitis A and B tests as well, which were hepatitis A antibody was reactive, hepatitis B was non-reactive apart from the surface antibody. We also did a HIV test as well, which was reactive. Otherwise, the TB test, we did an AFP smear test, which turned out to be negative. Toxoplasma tests and EBV tests too were also done, which were all negative as well. We also did a liver puncture as well, of which the fluid was clear, showed 94% lymphocytes, glucose was 46, and the protein was 49, with the other tests pending. And I could also go ahead to talk about the imaging, if that's okay, great. Yeah, so we did an EKG. The EKG was essentially normal. We did a chest X-ray as well, which showed a large anterior chest wall mass, as well as T11 vertebral body loss and associated bony metastasis on the T11 vertebral body. Otherwise, the lungs were clear. There was no pneumothorax, pleural effusion, heart borders were normal, no hilar lymphadenopathy. I believe Dr. Chang has the imaging for that, if he wants to show that. Yeah. So it just showed a large anterior right chest wall mass, but otherwise, and the T11 vertebral body lucency, but otherwise was essentially normal. We also had a CT chest, which was done, which showed the same thing, the large mass in the right anterior chest wall, as well as bony metastasis in the T11 vertebral body. But otherwise, the rest of the CT abdomen and pelvis was normal. Liver, pancreas, all other pelvic organs were normal, and no other like bony metastatic lesions were seen or identified on the CT cap.
Sorry, Tosin, I didn't catch the CT read. So was there invasion at all? Can you just repeat the description of the mass?
Yeah, just a large right anterior chest wall mass between the axilla and on the lateral side of, on the right lateral portion, and the T11 vertebral body loss. But otherwise, no other invasion anywhere else. It was not originating from the viscera, to your question, yeah.
Thank you so much, Tosin. What a case, team. Thank you so much for presenting. This is so educational. Bettina, yes, what are your thoughts?
For me, I'm thinking right now that this is an HIV-related condition, which predisposes our patient to aggressive B-cell lymphomas. That's my first thought. Although his CBC doesn't show like this kind of issues. Now, I'm also thinking, this patient doesn't have rash, but I would still like consider other reasons such as sarcoma, I'm also thinking that this large anterior chest wall mass with bone metastases, I'm thinking where I will try to look for the origin, especially like if there is any, like if this comes from like the chest mass. I'm also thinking like being in such a state of immunocompromise, there are also many infections, which would be like my differential diagnosis, such as fungi. This would be TB. This could be other, although it's EBV negative, I would like to know if this could also CMV negative. That will be my approaching. We need definitely this. I'm not very sure, like if I would do something else aside from AFB for TB. But yeah, what do you think, Bettina? This is very interesting.
Yeah, I totally agree with you, Yaz. I was also thinking again about what I said before, that it could be in a background of malignancy, but the patient is immunocompromised and probably predisposing to infection. So right now with the HIV, what also jumped out at me, same as Yaz, was that it could have been lymphoma that was related to EBV, but then the EBV turned out to be negative. So it kind of threw me a little bit. But yeah, I also want to think about different diseases, like what Yaz mentioned. Fungi could also be nocardia, actinomyces. For the TB, I'm also not sure if we stop at the AFB smear, or if there's something that we can still further request that could give us a clearer picture if it's really TB or not. I was also thinking about, again, the hypercalcemia, and I remember that it can also be common in HTLV. So that's also something that I'm considering at the back of my mind. So yeah, so how about you, Dr. Charmaine?
Yeah, lots of things to consider, as you mentioned. And to be honest, I don't know what this is. So how do we go about figuring it out? I have no idea. So I think, again, like making sure in some case complicated like this, to work up different component of it, and at the same time trying to see if there's any way we can relate all of these findings together, right? So I think, again, we still need to do our fuller hypercalcemia workup to see if there's any clues there that can help us make diagnostic process. The mass itself, quite interesting to me. I was like thinking like whether there's any invasion to the surrounding structures, like does it look like it didn't quite look like an abscess? Thinking about like whether this is like a muscle or kind of a soft tissue malignancy like a sarcoma, or is this kind of a breast malignancy? Of note, like CT imaging in general, not great about breast usually be like a mammogram, right? So again, thinking about what are the deficiencies in the diagnostic tests that we do. I think tissue is the issue. So this is a good time to get a sample. And I think what the beauty of a sample is that you can get a better sense, and also you can do all of the infectious workup that you all are worried about, right? So you can like stain it for TB, thinking about is there anything else that is infectious wise going on, so sending it for cultures, thinking about the HIV with a CD4 count of 19. So this patient is severely immunocompromised. Thinking about all the malignancies, and also infections that this patient is at risk for. Kind of coming back to the cats that this patient has been around to. So thinking about Bartonella as well in this case. So the other thing that I would do is that I would like get kind of a head imaging in this person as well. So thinking about either starting with a knock-on head CT or an MRI to think if there's any it's a central nervous system involvement, giving people with severe HIV are at higher risk of lymphomas and central lymphomas as well. The one thing about the lesions, and HIV, again, like Kaposi sarcoma comes to mind. With Kaposi, there's a gap in my knowledge. I don't know if it actually metastasizes to bones or not. I've seen visceral involvement. I can't remember knowing bones. So if anybody knows that and want to teach me, I would be grateful. So again, many things on the diagnosis. I would thinking about biopsying the lesions, send more serological workup, and also then thinking about consulting our infectious disease colleague with a person who's coming in with a new diagnosis of HIV. All right, can't wait to know what you all did next.
Yeah, we also had a CT scan of the head, which showed an enhancing right frontal calvarial lesion, which is measuring about 2.5 centimeters in craniocaudal extent. But otherwise, no evidence of an acute impact, hemorrhage, or other mass effect shown. I would
Yep.
yeah.
And I might just add that we were not satisfied with the CT brain, so we ended up getting an MRI of the brain and a CT angio. And the MRI of the brain and the CT angio showed marked abnormal enhancement in the bilateral 5th cranial nerve and also bilateral 3rd cranial nerve, in addition to the extracranial and intracranial lesions identified previously on the CT. There were no parenchymal invasions. And with the T11 pathological fracture, we also got an MRI of the C-spine, T-spine, and L-spine. And the T-spine again demonstrated the pathological fracture of T11. C-spine and L-spine were normal.
Just in the because of the time, do you all want to give us any other data you have until like maybe the final diagnosis?
I think that the next piece of data would give you your final diagnoses.
Okay, beautiful.
Yeah, so we went ahead and did the lymph node biopsy, and that showed a diffuse large B cell, high grade metastatic lymphoma. And so I guess that kind of cleans up that final piece for you.
Bettina, yes, any comments?
I am, as Dr. Ravi would say, I'm flabbergasted with this diagnosis, the diffuse high-grade metastatic lymphoma. I think that with a patient with this HIV CD4 count, that's one of the main thoughts when I'm thinking, when we see this kinds of like aggressive, like all this presentation. Although I'm wondering, did you do like any bone marrow study, like how the patient did? That's something I'm still trying to process all of this information.
Yeah, Bettina, any thoughts?
Yeah, I'm still trying to wrap my head around the diagnosis. Honestly, it's super incredible. I would love to commend all the residents for such an incredible case. Well, at least the bilateral ptosis was answered. It was due to the enhancement, as you can see in the MRI. There was an abnormal enhancement of the cranial nerves. So I have so much to read about diffuse B-cell lymphoma. And it's so beautiful how we went from chest mass, and then we were trying to gauge if it was infection or malignancy, and then there's a background of HIV, and then later on we were thinking maybe we try to veer away a little bit from the lymphoma and see if it's an infectious cause, and then we're right back at it again. So it was really interesting. It was a fun journey. Definitely more things to read about and learn about. So thank you so much.
Yeah, absolutely. Thank you guys so much for presenting this case. So educational. I learned a ton thinking about it. So yeah, one thing I like to do is always like go back and make sure the final diagnosis explains all of these findings, right? We were wondering how, as Bettina mentioned, like the ptosis is really the chest wall mass, and then we got the HIV diagnosis, and then thinking about the hypercalcemia as well. And so all of these things, yeah, you know, on the differentials is either like a really terrible systemic infection that is like granulomatous in nature, or is it a lymphoma? And unfortunately, the LBCL, you know, which I think in the setting of HIV does unfortunately convert some poor prognosis. So I'm curious to know how the patient did. But yeah, learned so much. You know, lymphoma can do anything.
Yeah, Charlene, he's doing well. Actually, he's currently admitted, getting R-CHOP. So he's doing well. As soon as the chemo started, and we also did intrathecal methotrexate as well. You know, his eye, the ptosis resolved within a couple of weeks of starting chemo. His chest mass went down almost immediately. It resolved pretty quickly. And so he's doing well. He's getting treatment for both his malignancy and his HIV. And he's adherent, so he's doing well.
I'm so grateful to hear that. I'm very grateful for you all for taking care of this patient. Thank you so much and teaching us so much.
Yeah, amazing case. The chat is on fire, asking a lot of questions. It was really great. Thank you so much for presenting for us. And I think now we can ask a few questions for the program. If anyone want to add to the chat, or Francisco and Sarah that help us with the whiteboard want to ask us a question. I think as a IMG, my question is always like, how do you feel in the program? How do you feel being from another country? And like having said that he's from Canada, was in Australia, and now is in the US. I have a background a little similar. I'm from Brazil, I'm in Argentina, and going to the US. So how do you think the city, the program treat you, and if you can tell us a little bit? Kevin.
Yeah, I feel like the program is relatively new. We only had our first class around 2-3 years ago, and the vision and the mission of the program is pretty clear. They want to train internists who will stay and serve the area, which is also very underserved. And our program actually has a lot of IMGs. But one thing I noticed in common is that all these, whether it's IMGs or more domestic students, all of us have this interest in staying in this area to serve after our residency. So that's a really important thing for our program. Otherwise, our program is very inclusive. We have a very diverse background of faculty members, and actually a lot of our faculty members are from other countries as well, are from Canada. So in a way, it really makes you feel home.
Like, I also have a question, like very related to this. Like as an IMG, what is one of the most valuable aspects of your program? Like that it could be didactically speaking, or even the city. What has been something that has made you say like, hey, this has helped me to integrate myself easier to this PGY1 life?
Yeah, I can try and answer that. I think didactics were definitely helpful, but I think my biggest blessing has been learning on the fly and having a lot of support from our faculty and attendings and senior residents. I'm in the second class, so I was lucky enough to have a class of senior residents, and I know the first class didn't have that. And so I think having supportive co-residents is huge, and supportive faculty, and that's made immersing into the US medical system really quite flawless. So it's been helpful.
I would also agree with Aisha here. Having just a very diverse faculty as well as residents has been very helpful. Having like diverse experiences from even just the residents, and helping to like teach us and build us up has been extremely helpful. And, you know, having different experiences, people share their experiences coming from the different countries, as well as from the different medical systems. It helps me to feel even more comfortable in just integrating into the system. Yeah.
And we had a question, what you all are most proud about the program, besides having these amazing people and sharing this great case with us?
What are we most proud about? Is that what you
Yeah.
asked? Oh, yeah. Honestly, probably the community outreach that we do. We're really mission driven with giving back, similar to what Kevin had said, and focusing on the community we live in. So we do a lot of community outreach, including street medicine, which is something that our program takes a lot of pride in. So going out and helping the less fortunate. We have a service event this upcoming week where we're going to be making like healthcare hygiene kits for our community. So we tried our best to do like almost quarterly, I think, something for our community. And it's part of a lot of our rotations as well. Our clinic experience incorporates community outreach, and we go to low income areas essentially and help give free healthcare to the community.
Yeah, I think one thing that I really like about this hospital is a lot of the patients we work with, they are really sick, and really they come from lower socioeconomical status for the most part. So these patients, I find that generally they are very grateful, and it's really gratifying to work with these patients and see that you can make a huge difference in their day-to-day lives. And they really follow up with all their appointments because they want to be well too, as long as they're given the resources.
I'll also add there's some really great continuity. So one of our major clinic sites is in the hospital. So I know the first time I came across this patient was actually during his hospital follow-up appointment with Dr. Chang, who helped discharge this person. So I think you get to build some really strong relationships for people who are really sick in the hospital, who might not have been in care for quite a long time, and then get to become their primary care doctor afterwards and sort of get to know them longitudinally.
I also have another question. I know that these are like information that is also on your webpage, but about mentorship, or like how do you get assigned, or do you reach out as a PGY1, or you have one established since you begin and until you finish? How does that work?
Yeah, I'm happy to answer this. Yeah, Yasmin, that's a good question. So we get assigned faculty mentorship when we start our program, and it's based on your interest. So you fill out a form based on your interest, geographical interests, and also like if you're an IMG, I was paired with an IMG, so it was helpful also in that sense. We also have resident mentorship. So a PGY1 will be paired with either a PGY2 or a PGY3, and you do stay with them throughout your 3 years. And we often adopt new mentors through the program as you get to know faculty and residents who you maybe have similar interests with. So the mentorship accumulates, which is kind of nice. I found that I've gravitated and adopted new mentors over the past 2 years.
One thing that's also new that we were planning to roll out this year is a clinical coach. So sometimes your mentors who are assigned to you may not actually have access to some of your evaluations. Each residency program has their own clinical competency committee who reviews residents' progress. And so this year, basically, whoever is assigned to review your evaluations, we actually try to have that person intentionally meet with you at least twice a year to just review all of your clinical evaluations or personal goals, and help with coaching towards just making the residency experience a little bit more personalized in terms of how to reach whatever goal you're working on, and not having these meetings just be for people who might be behind, but also for people who are high flyers and doing really well, making sure that we're spending the same amount of time on those folks too.
It completely makes sense now. Oh, we have questions on the chat. about research. Olumide asks how supportive is the program for research, and if there are research opportunities for people who may want to pursue fellowship later.
Okay, I can answer this too, because I'm second year and getting ready for fellowship applications next year. We had our first fellow acceptance this year, as we just our first year having a third year class. And so we were really excited. The program's definitely supportive in fellowship. We are in research, we're relatively new, so we're still creating a lot of relationships with different faculty. But, you know, if you express interest, the program does a pretty good job and pretty intentional job of trying to help you find somebody either up here at Washington State University or also down at University of Washington. We have some residents who do research with faculty down there as well. And a lot of our faculty is trained in the area. And so, you know, their colleagues, they're always willing to introduce us to their colleagues and get us connected with different people who have research opportunities available for residents. And maybe Dr. Yang can add, yeah.
Yeah, the third-year resident who matched in HEMONC this year did a lot of local clinical research with one of our HEMONC groups. So there's both research through Washington State University, but because we're clinically based out of the Providence Health System, you also have access to the clinical research that's happening through that group. And they actually have a pretty active research program through a couple of their departments.
Thank you so much for the insights. Honestly, I think that you answered the questions completely. And Bettina, do you have a last question?
Yeah, probably just more of outside the program, like what's the cost of living like? What activities do you like to do around the area? And, you know, food options, all of that.
Okay, I can answer it. So cost of living is, you know, it's the Pacific Northwest. We're a little bit outside of Seattle, which makes it more affordable. And we're about 25 to 30 minutes north without traffic. So yeah, that makes it a bit more affordable, but it is the Pacific Northwest, so it is expensive. I think that our salaries, you know, do a good job of compensating for what the cost of living is here. Food wise, we've got a few great restaurants right near the hospital. We're in Northwest Everett, so just north of like the actual central Everett, but we're right near the downtown. So it's like a little bit of a longer city that follows along a highway. Food here is good. The city of Seattle has amazing food too, and we're only 25 minutes north. Seattle itself has quite a few suburbs: Bellevue, Kirkland, Redmond, Everett being one of them as well. And all these cities bring a lot of diversity to the city, and so you get a lot of different cuisines as well. Dr. Yang always brings a bubble tea to the clinic, so it's like 9 a.m. I'm like, where'd you get that? How'd you get that? When are you going to bring them for the rest of us? But we always have, you know, there's like a ton of great foods from different backgrounds in the neighborhood, which is nice. And you know, on Sundays, if you're at the hospital, your attending will probably buy you lunch from somewhere nearby, so it's pretty good.
Thank you so much for all these insights about the city, about the program, mentorship, research. Like, even if you mentioned that it's a relatively new program, I see that it's very well-rounded. So I hope many people that is applying next year will be very, very interested in going over there. And yeah, being mindful of your time. I want to thank you all, Dr. Yang, Dr. Aisha, Dr. Kevin, Dr. Tosin, for coming here on a Saturday and discussing with us a case, amazing case. I will have to do a lot of reading right now. And yeah, CPS doors are always open for you whenever you want to present another case. And thank you so much.
Thank you all. If y'all have any questions, most of us have emails that are just our first name dot last name at wsu.edu. So we're easy to find.
Yeah, thank you so much for having us.
Thank you so much. See you later. Have a great Saturday. Take care.
Thank you so much.
Thank you all. The case was absolutely brilliant and your presentations were fantastic. Thank you.